I am a Boston Scientific clinical specialist, specifically for SpaceOAR, and I'm here to tell you a little bit about that. So SpaceOAR, if you don't already know, it's a product for men who have opted or elected to take the radiation therapy route for the treatment of the prostate cancer they've been diagnosed with. And the intent of SpaceOAR is to create some space between the prostate, which is the organ we're trying to treat or dose with the radiation to kill the cancer. We want to space that prostate from the rectum because the two organs sit in a very close proximity. And one of the primary consequence or side effect with radiation therapy historically has always been rectal toxicity. So there has always been a need in the industry for a spacing agent, and thus came SpaceOAR. There's been other spacing agents in the past. There's been balloons, there's been blood patches, high hyaluronic acid. But in 2015, SpaceOAR, we received FDA approval. It's a polyethylene glycol. And we've been placing it in patients successfully ever since. With that all being said, I'm going to share my screen because I have a few slides I'd like to show you just so you can kind of get a conceptual understanding of what I'm talking about. Sorry. Can everybody see my, can everyone see my screen? Are we able to see it? Yeah. You good? Okay. Yeah.
Yes.
So as you guys can see, I kind of went over the intent of SpaceOAR. It's a spacing agent to space the prostate away from the anterior rectum while the patient receives radiotherapy to reduce rectal toxicity, which it's a pretty big problem for a lot of men that have had prostate cancer and who have elected for radiotherapy. If they end up getting their rectum dosed, it can really limit the quality of life. They can end up with all sorts of issues, diarrhea, bloody stool, a host of things. Fortunately, there's been a lot of good developments, technologically speaking, not just with the spacing agent, but with what they're using to treat with, right? So their imaging has gotten more precise, as well as the delivery systems. But with all that said, I just like you guys to kind of look at the slide, and you can see I mentioned how the prostate sits in a very close proximity to the rectum. If you look at the image to the left, that's the prostate, right? And just below that is the rectum. And that's pretty accurate. In a lot of cases, men have next to no space at certain parts of the prostate where the rectum is. And it's very hard for the radiation therapists, as good as they are, it can be very difficult for them to properly treat the prostate without their margins getting into the rectum. And what I mean by margins is when a radiation therapist and his planning team develop their plans, they have a dose volume histogram that they use. And what you see here, this little dotted line, that indicates what they call a PTV, planning target volume. And there's typically will be about a 5 millimeter margin, maybe a 3 millimeter towards the posterior of the gland. And the reason they try to keep it tight at the posterior is because of the organ at risk, which is the rectum. So that's what OAR stands for. So SpaceOAR is organ at risk. And as you can see, what we do is we take a small needle, 18 gauge needle, and under ultrasound guidance, we will guide that needle between the prostate and the rectum, and we will inject a hydrogel. And what that does is it creates sort of a pillow or a cushion between the prostate and the rectum. And you can see with the image to the right, and you can see how that will lift the prostate out of the treatment zone, or yes, the rectum. It'll push the rectum out of the treatment zone, and that will spare the rectum any nasty side effects if done correctly. So generally, just a general overview of what I said, guys. As you can see, we aim to create 1 centimeter of space, and that's pretty accurate. That's what we achieved in our pivotal trials, and that's what we're seeing on a regular basis. So more space equals less radiation. We saw a 73% reduction in radiation delivered to the rectum in our studies, and that led to 70% less side effects, grade 1 toxicity. We didn't have any grade 2 toxicity in our pivotal trial. And that will overall lead to just a better quality of life for the men that decide to choose for radiation, take the radiation route. And just to briefly touch on what PEG is, polyethylene glycol, that's the active agent in our product. That's what we're going to be putting between the prostate and the rectum. So this image to the left, this is what they call a sagittal image of the prostate. So it's a longitudinal view. If we were to take a longitudinal slice of the patient's anatomy, you can see the prostate, the prostatic urethra, and the bladder up here. What we aim to do is go through the perineum with our needle and insert that gel between the prostate and the rectum, as you can see. You can see these are all MRI images to the right. So we can see pre-implant, you can see the prostate, which is the dark gray right here. I'm circling it with my mouse, and then you can see the rectum just below. You can see how tight it is, how little space they have. So that's pre-implant, and then post-implant, this is 3 months after. That you can see the gel. The gel is lit up in white on the MRI. And after 3 months, the gel will then enter into a phase of hydrolysis. It's designed to do that. What it does is it breaks down, and after 6 months, it totally dissolves. You basically pee it out, and it leaves no trace. So while it is an implant, it is not a permanent implant. One thing about PEG, polyethylene glycol, they've been using it for a long time, even longer than they started using it as a spacing agent for prostates. So they were using it, they use it a lot in craniotomies and spinal surgeries. There's a product called Duraseal. In fact, that was how we were able to get the pretty quick 510K approval from the FDA. We knew we were already using it in surgeries, so we knew it was safe. And yeah, so that's what it is. It's polyethylene glycol. You put it in after 3 months, it'll hold its form up to 3 months, enter into a phase of hydrolysis, and then after 6 months, it should be totally absorbed. And I have that's pretty much it as far as slides, but I had a brief procedural video. It's kind of like a cartoon, but it kind of it's very short. If you guys, are you interested to see it? I'll just play it.
Yes. Go.
I'm sure they are. Yeah.
What's that?
I'm sure everybody is. Yeah.
Cool. So it's just kind of like a cartoon sketch of what we do. Hopefully it plays for me. So we'll give it a chance here. So right now they're just kind of identifying the anatomy. You can see the prostate. And again, we're in a sagittal longitudinal view. You can see the prostate, you can see the perirectal fat, you can see the rectum. And it's a little choppy on my end. I don't know how it looks on your end. But you'll insert a truss probe, transrectal ultrasound probe. That way we can keep the anatomy and the needle under image guidance the whole way while we're doing the procedure. And by the way, this procedure can be done under general anesthesia, MAC, or local, depending on what the doctor's choice is, what's best for the patient. It's not all that invasive when you consider, some of the other modes of treatment. It is an 18 gauge needle and a probe, but aside from that, what they're doing now is they're hydrodissecting. So that's something we do to ensure that we're in the right spot. One, we're keeping it under image guidance to assure we are guiding it into the exact spot we want it. We hydrodissect to confirm we're in the right spot. That way we're not injecting it into a place it's not intended. Once we get the confirmation, we insert the gel. And it's pretty simple. The procedure only takes about 15 minutes once we get the patient positioned and prepped. It's about a 15-minute procedure. That's pretty much it. That's kind of the simplified explanation of what SpaceOAR is. All
right, I'm going to turn it over to Dr. Babbar.
Awesome. Thank you so much, Joe. So I wanted to today talk about life after prostate cancer. I think that once men get the diagnosis and then you wade through all your options of prostatectomy, radiation, hormones, whatever it may be, that's what is in front of you at that time, and certainly what we have to focus on with your oncologist. But so I'm a reconstructive and prosthetic urologist, and I really have a passion for and focus on life after prostate cancer, specifically issues related to sexual health and sexual function post-prostate cancer treatment, and then also things related to continence and avoiding. So as Joe said, my name is Paurush Babbar. I grew up in Melbourne, Australia, and I moved to the States for high school, and then went to Wake Forest in North Carolina for my undergrad and medical school. And then was fortunate enough to match at what I think is the preeminent urologic institution in the United States at the Cleveland Clinic, where I did my residency. And then I was fortunate enough to stay on for a fellowship in male genitourinary reconstruction, men's health, and prosthetic surgery. My specialties are listed there, and I see patients at the Eastgate and Norwood locations, and my practice is about 85-90%, men's health and things of this nature, and I do a little bit of general urology, but not too much. So, next slide, please. So these statistics, I think everyone in this group certainly knows prostate cancer is the most common cancer that's not skin cancer in America amongst men. 1 in 9 men will be diagnosed with this in their lifetime, and this accounts for nearly 3 million men in the United States who count themselves today as prostate cancer survivors. And so the things we want to focus on today are some of the side effects of treatments for prostate cancer, namely urinary incontinence and then erectile dysfunction. So focusing first on the incontinence part of it. So after prostate cancer treatment, especially this is most commonly, I would say, seen in post-prostatectomy, that you can have leakage of a few drops of urine all the way up to just a total, incontinence. And so we know that patients right after prostatectomy will likely leak a little bit for the first few weeks to months. And so we, our prostatectomists and urologic oncologists will recommend patients have pads ready. But over time, we find that within the first year, about 90 to 93% of men will regain their continence to the point that if you were to bench press 200 pounds, you're going to leak a little bit. Okay, like I think that is going to be inevitable after a prostatectomy. But I think that most men are what we would call socially continent, that they are dry, maybe a few drops here or there, or one small guard a day. And so, there are 7 to 10% of men who will suffer from persistent stress urinary incontinence, or what we call post-prostatectomy incontinence after surgery. And so, I'm always I think this is one of the parts of prostate cancer survivorship that isn't discussed enough. So I've now been with the urology group for 2 years, and I've seen patients who had their prostatectomies in the 90s, and they've been leaking 7-8 pads a day, and no one has told them, or they haven't heard about ways to help with that, and they become recluse in the house. They don't go. They're told they smell. It's just, until you lose your continence, I don't think you realize how important it is to a human's life. So I think so yeah, I can go to the next slide. For mild leakage, these are what we would tell patients even pre-prostatectomy to buy. So absorbent pads, then there's adult diapers. That's when you're getting more severe incontinence, and then there's catheter collection devices or condom catheter, which I rarely would recommend, penile clamp or a Cunningham clamp. So that just is a mechanical force that occludes the urethra and prevents urine from draining. And then Kegel exercise. So this is an interesting component. I'm sure many of y'all have heard of this. So these are pelvic floor strengthening exercises that a lot of times the prostatectomist will recommend pre-surgery and after surgery, especially once the catheter is out, to strengthen the pelvic floor muscles. Reason being, there is some evidence that this can help regain continence sooner. So it's not a bad idea. And certainly, since I've joined the urology group, mirroring off some of our experiences at the Cleveland Clinic, we are doing what we call pre-prostatectomy rehabilitation. So we have it's a visit with patients who are about to undergo prostate cancer treatment, and their surgeon or their radiation oncologist will talk to them about the cancer and the nuts and bolts of that, but then they'll have a meeting with me about these issues about incontinence, having pads ready, doing Kegels preoperatively. Then in regard to erections, we a lot of times will start patients on a low dose PD5 inhibitor such as Cialis. We will offer them a vacuum erection device, and then there's penile traction devices known as Restorex that can help with penile length post prostatectomy. So and we'll talk about that later. But so I think this is part of prostate cancer survivorship and things of that nature. So Kegels exercises and pelvic floor physical therapy has certainly been shown to be of benefit. Next slide. But then if the patient post-treatment has moderate to severe leakage, so what I would define as probably 2 pads and above at that point, and even if it's one large diaper, I mean, I think as long as if it's bothersome to the patient, it's bothersome to me. And so we would have a discussion about how what we can do for this. So essentially, I think there's 2 main treatments for post-prostatectomy incontinence, right? So one is slings, and so slings are it's a polypropylene mesh, and it essentially acts as a hammock to provide support to the urethra and prevent leakage. I think the best candidates for male slings are patients who are non-radiated. Okay, so someone who's not had like a salvage radiation or something of that nature, is the erosion rates have been shown that they can be higher, and more importantly, I just don't think they work that well in that patient population. And also patients who have maybe 2, maximum 3 pads a day. I mean, once you're leaking more than that, I just think a sling may minimize it somewhat, but it's not going to get you to be socially continent. So, but it is a great option in well-selected patients, and it's a outpatient procedure. Takes me about 45 minutes to an hour to perform. You have about a 3-4 centimeter incision in the perineum, right underneath the scrotum. We dissect down to the urethra. We split the bulbospongiosus muscle, dissect around the urethra, and then we pass these trocars to pull the sling in position and tension it under cystoscopic guidance. And then the patient, generally I send them home with a catheter in for about 3 days, and then we pull that out, and at that point, they're going to have some benefit from that. Next slide. And so then the workhorse surgery of what I would say when patients have severe post-prostatectomy incontinence is an artificial urinary sphincter. Essentially, as that diagram shows, there's a cuff that's around the urethra. There's a pump that's in the scrotum, and then there's a pressure regulating balloon or a reservoir of fluid that we tuck inside the abdomen. So all of this is on the inside. None of it is seen. You can go through an MRI. It's fine. Airport metal detector. It's fine. No one's going to know. You can be in a locker room. It's not going to be obvious. And so the way this works is the cuff that is around the urethra is closed at baseline. And then when you feel the urge to void, you grasp that pump that's in the scrotum. You give it 2 to 3 squeezes, and that cuff will open, and you'll pee. And then on its own, about 45 to 60 seconds later, the cuff will close, and then you're continent again. So this procedure works, I think, quite well in well-selected patients even who have had radiation. We certainly offer this in patients who have higher volume leakage. Generally, there's 2 incisions with this one, underneath the scrotum to dissect out the urethra, and then 1 incision on the abdomen. That's where we tuck the pressure regulating balloon behind the abdominal muscles or the rectus muscles. So I did about 35 to 40 of these cases last year, and we were one of the highest volume centers for sphincters in the country. So we have a good experience with this. So this is a a video of this. Yeah, so this is showing the pump right there in the scrotum, and then the cuff right there around the urethra. And there's a few surgical things that we do. We like to keep the cuff as proximal as possible, meaning as close down in towards where the prostate was as possible. We don't use something called tandem cuffs, which are two cuffs. We just use one. There's certain sizing. The sizing is critical for, you don't want to over tighten it, because then there's a risk of erosion, which is when the cuff can come through the urethra. So it has to be perfect. You don't want it too loose. You don't want it too tight. So I think that just comes down to a bit of clinical gestalt. It's important that patients don't, we let them know that if you end up in an ER, don't let them put a catheter through unless they call a urologist, because we can put a catheter. You got to deactivate it and put a small catheter, but once in a while an ER will try to jam a catheter through a closed sphincter. They'll get it through, it'll open, but then a lot of times then that's when erosions happen. And then it's an outpatient surgery. It takes about an hour and 15 minutes. Go home the same day, no catheter, no drain. And then I see the patient 6 weeks later to activate the device. So right after surgery, you are just as incontinent as you are before. We got to let the area heal in, let the device, we don't want it squeezing on the urethra that's been freshly dissected because there is some edema or inflammation there. And then 6 weeks later, we teach you how to use it, and you walk out of the office continent. So, yeah, I think it's out of all the surgeries I do, the sphincter is undoubtedly my favorite, because it really can have an immense impact on the quality of life of patients who are afflicted with post-prostatectomy incontinence. So, and so this is the website fixincontinence.com, which is through Boston Scientific. So they're the only company that makes the sphincter, and so they have just some more resources there. So shifting focus a little bit onto sexual health. So erectile dysfunction, as we know, can a lot of times go hand in hand with prostate cancer treatment, and that's whether radiation, prostatectomy, or hormones. We think that 45 to 55% of men post-prostatectomy treatment can have erectile dysfunction. I think a lot of it relates to what the patient's erections are like preoperatively. So certainly if someone has pretty poor erections going into, let's say, radiation treatment, they're not going to be getting any better. Okay, so that's what I would say. It can take as long as 2 years to regain sexual function. I think this is more related to post-prostatectomy. I think with after prostate removal, you see this side effect of erectile dysfunction, for the first 12 to 18 months, it can be, and even up to 2 years, but it's, if it can start getting better over time. With radiation, you likely for the first 2-3 years will not see an appreciable decline, but then sometimes in those patients who get a hit, it can be pretty remarkable at the 2-3 year point, and then generally that does not get better. So it's kind of one of the things I talk to patients in our pre-prostate cancer rehabilitation visits. By the time they see me, they've a lot of times decided if they're doing radiation or prostate cancer, but sometimes they don't. But I think part of it is, do you want to take the risk of side effects right away, or do you want to take them in the long run? And I'm not saying that everyone gets the side effect, but that is something that you can think about that way. So, some of the treatment options for erectile dysfunction, oral medications, which we all know about. These are things like Viagra, Cialis, Levitra, Stendra. These are PDE5 inhibitors. What they do is, through the nitric oxide synthase pathway, increase blood flow to the penis, and can help with erections. Then there's vacuum erection devices or vacuum pumps. So that's that top right diagram. So it can be hand or battery operated. It goes over the penis. and there's a constrictive band that goes at the base, and then it sucks blood into the penis, and the band helps to prevent blood from escaping back out. And I think that the thing with vacuum devices, I think I have a few patients who like them, but generally there's a high discontinuation rate because the spontaneity with the vacuum erection device is not the best, and then it sometimes can be uncomfortable to have the constricting band, and it's cumbersome to put this device on and things like that. But I have found that one area that is I think fruitful for the vacuum erection device is in this penile rehabilitation phase of after prostate cancer treatment, especially prostatectomy, which is after the prostate's removed, the catheter is out. You start doing this to help promote some blood flow to the penis, and there's some evidence that this can help restore erectile function sooner. It can also, we think, help prevent some of the loss of length that a lot of men complain about, which I think some of the urologic oncologists that I trained with would refute, but I do think there is some truth to that, because once you have your bladder, your prostate, your urethra, you take out the prostate, you have to accordion, I think, the urethra in a little bit to sew it to the bladder. And I think there is some inherent loss of length that patients can see at times. And part of it is also that there's what's called corporal fibrosis, or scarring in the penis, because you're not getting good blood flow into the penis, and then it starts to shorten. So I think the vacuum device can really help get some blood flowing early on in the treatment course, and hopefully prevent some of that corporal fibrosis or scarring. There's a traction device I alluded to earlier called Restorex. So this is a device that was invented at the Mayo Clinic in Rochester, and it was originally used for a condition called Peyronie's disease, which is adult onset acquired penile curvature, and it was used to essentially pull the penis in the opposite direction of the curve and try to correct the curvature. There was a recent study that was used in post-prostatectomy patients, and instead of pulling the penis back, you can actually also stretch the penis, this traction device. And they found that those patients who used the Restorex device for about 16 weeks, twice a day, post-prostatectomy, had less loss of length as opposed to their counterparts who did not. So now the thing is, it's about $500 to get a Restorex directly from the Mayo Clinic, and it's not covered by insurance except the VA, so it can be a little costly, but it's something that I certainly do mention to some of my patients I see. Now, penile implant. So one thing actually we didn't go into is injections. Okay, so this is intracavernosal injections that patients will directly inject into the penis. So instead of a pill like Viagra or Cialis that goes throughout the body, and you can see some side effects like headache, facial flushing are the ones I hear most. The injections, they go directly into the penis, and 5 to 20 minutes later, you generally get a nice rigid erection, and then it works pretty well. There's 60 to 80% patient partner satisfaction with injections, the main side effects are these are sticking a needle into the penis. There can be some bruising and pain, and then sometimes the risk of priapism, which is a prolonged erection lasting longer than 4 hours, and that a lot of times the patients have to go to the ER. But luckily, that's a pretty rare occurrence if they're dosed correctly. So there is some discontinuation with injection, just because I think a lot of men are not too enthused about putting a needle in their penis. And then lastly, the spontaneity is a big thing I hear with the injections, because it has to be frozen. So you got to go to your freezer, thaw it, inject. And so by the time you've injected and the medicine's taken effect, the mood can pass a little bit. So, but it is certainly an option. One other thing to touch on are these newer treatments, let's say, that haven't made guidelines or things like that. So one is penile shockwave therapy. So this is all over, advertising, things of that nature. And so, and we at the urology group also offer all-medulla ultrasound wave therapy. I think in this patient population, which is prostate cancer survivors, there's been 4 studies. 3 of them showed no benefit to shockwave therapy. One was equivocal. So I certainly, when I see patients, I say, look, you can try penile shockwave. So that is meant to address the root cause of erectile dysfunction, which is decreased blood flow to the penis. And some randomized clinical trials out of Israel and Europe have shown that it can help with blood vessel formation, stem cell proliferation, and nerve regeneration to the penis. But the increase in erectile function scores are good for mild to moderate erectile dysfunction. But in patients who've had prostate cancer treatment, I don't think there's benefit. But I once in a while have a patient who will still want to do it, and I think there's nothing wrong with that. There's no evidence of any downside, no hematomas, blood collections, penile pain. But as of right now, it is an out-of-pocket cost in the United States. In Europe, it's in the EAU guidelines, first line with Viagra, Cialis, things like that. But in the United States, it has not made it there. So it is an out-of-pocket cost at this time. And I just caution patients in that regard that if you're going to do it, you want to find honestly, have a urologist be the one who takes care of these issues, because a lot of the entities going around the whole United States right now, I would just caution to ask, where do they train? What's their residency fellowship in urology? Like, you don't want a pediatrician administering drugs on your penis, or at least I wouldn't. Anyway, so penile implants. So this is a short surgical procedure that can help regain erectile function in really all patients who have severe erectile dysfunction, and certainly patients who are post-prostate cancer treatment. So just like the sphincter, it's a 3-piece device. There's a pump in the scrotum. There's 2 cylinders that go in the erection chambers of the penis, and then there's a reservoir that we tuck in the abdomen. So when you want to have sex, you pump in the scrotum a few times, and it pulls the fluid from that reservoir up top into the cylinders, and then you have sex, and then you can actually keep having sex even after orgasm as long as you want. And then when you're done, you press the deflation valve, which is at the top part of the pump, and then it pushes the fluid back from the cylinders into the reservoir. So it has a pretty natural feel, because that's always a question, does it feel natural? I think it is a very natural erection. The main difference is, so a regular erection, let's say the head of the penis gets engorged. In this, the head of the penis, the glands, blood supply is predicated on the urethra, which is underneath. So you can still get some blood flow there, but it may not be as vigorous. But the rigidity that patients who have been suffering from erectile dysfunction and had not very good erections will get in the shaft is remarkable, and certainly even if the glands or the head is a little floppy, the penile implant is rigid enough to overcome that for penetrative intercourse. One huge thing cannot be underscored is the spontaneity. I think part of sexual relations, a lot of time, that is important. And once again, just like continence, you don't think about it until you lose that, and you have to do treatments like vacuum or injections where spontaneity can be a problem. So with the implant, once you're facile at pumping it up, it takes 20 seconds and you're ready to go. So that's good. It's completely concealed. You can go in a locker room, airport metal detector, MRI machine, no problems, and it maintains the erection as long as you desire. So there's 3 different models of penile implants. Okay, so there's that. Let's just show the video of this one first, and I'll touch on the other 2 just for completeness sake. All right, yeah. So the model there is pumping up the pump in the scrotum, and then it's pulling the fluid from that reservoir that's tucked in the abdomen into the penis. They get a nice rigid erection, and then when they're done, they press the little deflation valve that's on the top of the pump, and that pushes the fluid back into the reservoir, and then the penis is flaccid. So I think this is a very elegant and great solution. And interestingly, the penile implant in some form has been around for over 40 years. It was around longer than Viagra has been around, and has really stood the test of time. It's something to consider. So there's two other types of penile implants, okay, generally speaking. There's just malleable rods, okay, so you don't have a pump, you don't have a reservoir. These are just two rods that go in the erection chambers of the penis, and they just bend up and down. So they're made out of nitinol, and they just are, they just bend. So when you want to have sex, you bend them up. Otherwise, you just bend it down. And so people will always ask, like, does it look like I have an erection the whole time? And generally, if you're not, I would say if patients are super skinny, I think potentially, but if not, then you generally are able to conceal it pretty well. Question would be like, when would you consider doing that surgery as opposed to a three-piece? I think three-piece is generally my default, unless, let's say, patients don't have good hand dexterity, they couldn't manipulate a pump. That's something to consider in patients who have had, scarring and need revision surgery, or an infection that we need to take one out and put one in. I mean, that's one. And then some patients just don't want to have a inflatable one, and they'll pick it. And then but generally I think the three-piece makes sense. And then kind of in the middle of the two, there's one that has it's called an ambicor penile implant. It has a pump and then the two cylinders, but there's no reservoir of fluid, and the fluid in that is housed essentially in the back of the implant. And when you pump it up, it goes like all through it. It goes more to the front, and then when you're done, it goes back to the back. So it does deflate, somewhat. And I think it's a good solution. But generally speaking, I've only in the past year, so we did about 97 prosthetic cases last year, and one patient we did that, and that was because he had just mesh all throughout his abdomen. There was nowhere safe to put that reservoir. And so, that's a very extenuating circumstance. I think patients either mostly lean towards the three-piece and otherwise malleable, like that ambicor. I mean, we could do it, but, I think I can generally find a space to put that reservoir, because I think the erection is just a lot more physiologic with the three-piece, and when the penis is certainly flaccid, it has a more natural feel too, which is important, because the majority of the day you probably aren't going to have it inflated. So. Yeah, this I guess is a video of a penile implant surgery. No, of a inflation. Yeah, okay. So this is an actual patient, yeah, who's going to inflate and deflate their implant. So as you can see, this patient, he's going to, with your left hand, you kind of, I tell patients, you grab where the tubing is, and then that holds it in place, because the penile implant pump will move just like your testicles move in the scrotum. If it doesn't move, that can be a sign of infection. So moving is a good thing. And then you press it a few times, and then it inflates. And so the amount of fluid we put in the implant is tailored for that implant. So you cannot overinflate it and pop it. So that's a question that patients will have. And then one common thing patients ask, and I totally get it, is size. Like, we want, the biggest one possible. And certainly, we're very aggressive in how we size the penile implant, but I it's all about expectation management. I let patients know that a lot of times we think of our penis when we were 20 years old, and once you've had erectile dysfunction for a little while, the penis starts scarring. So if you take your penis right before surgery and you pull it on stretch, that's your stretch penile length. That's about how long the implant will be. And that's how long the skin is. You can't put in one way longer than that. And, I have no reason to short change anyone. So essentially, but that is something that, we always do go over. So, once again, this is just a website to kind of get more information, edcure.com. And then one thing I do want to bring up as well. So there's also, it's not in this slide deck, so there's a condition that happens in patients who generally post-prostatectomy, where their continence is good, erections aren't very good, but they're leaking during climax. So this is something called climacturia. And so, it makes it difficult because they start leaking urine right as they're about to orgasm. And so that can be distressing to them and the partner. So there's a newer surgical technique that we do for that, which, is only been around the last few years, but I think it worked remarkably well. So at the time of the penile implant surgery, because they have erectile dysfunction as well, we put a sling actually right across where the penile implant cylinders are, so that when the penile implant is pumped up, it tensions the sling on the urethra so that it doesn't allow urine to leak through. And so there's some evidence that it can even help in patients who have just very mild post-prostatectomy incontinence, but it certainly helps at the time of intercourse so that you're not leaking, on your partner. So that and it's been a very it's called a penile implant with a mini Jupette sling. So that's been very good. So, and then one other thing I wanted to bring up, I made a note of. So a lot of patients who will have post-prostatectomy incontinence may also have erectile dysfunction. So then the question becomes, what do you treat first? Can you put a sphincter and a penile implant in together? The answer is yes, but generally I think the best way to go is you put a sphincter in first, because you can't really have sex if you're leaking 10 pads a day. I mean, so it's important to get dry first and then heal up, and then about 4 to 6 months later put in the penile implant. The reason I think not to stage them is that these are prosthetic devices, right? So any prosthetic you put in the body, artificial knee, hip, heart valve, there's a risk of infection. So with, penile implant sphincter, the risk is about 1 to 2.5% in, non-diabetic, non-HIV, non-kidney transplant patients. So I think that if you do both of these surgeries together, the surgery takes longer, the skin is open longer, the implants are exposed to the air longer. So the risk of infection, I think, can go up sometimes, and the risk. So I think it's better to stage these procedures. And in my hands, I think doing the sphincter first, getting dry, healing up, and then putting the penile implant in makes the most sense. So these are just some frequently asked questions. So we answered the first one that, approximately 1 in 10, 7 to 10% of men can have persistent incontinence after prostatectomy, and 1 year following, if you're leaking like 10 pads a day a year out, waiting is not going to get things better at that point. So I just tell patients, don't be like some of these unfortunate patients I've seen who've been waiting since the 90s just leaking. I mean, come in, this is something that is totally addressable, and I mean, we would love to help. And then, why don't all men recover erectile function after treatment? Ability to have an erection after prostatectomy can be affected by, of course, pre-existing risk factors, age, diabetes, cigarette smoking, and activity, things like that. So, every patient's different, I guess, is that. And then insurance is always a big question. So, essentially I would say we'd have to run the insurance, but I found that Medicare generally covers the penile implant and the sphincter, and so, as do most insurance carriers. Medicaid is generally a little harder, but with our volume that we've been doing, we have a pretty robust benefits department, and we've been able to push through a lot of things and appeal and things of that nature, and even Boston Scientific helps us get through. So these are just some real patients and some impactful quotes they've given. So from Roy, after 7 years with the male sling, I still find pads in a suitcase or a jacket that I haven't worn. It would be hidden in the pocket somewhere. I laugh and think, thank goodness I don't wear them now. We just certainly hear things like that a lot. And then prostate cancer surgery left me both incontinent and with ED. After having the AUS, I could go places again and do things socially without risk of embarrassment. Now that I didn't have the incontinence problem anymore, I was ready to deal with the ED. When I had the penile implant, I felt completely whole again. It restored my confidence and restored my life. So yeah, and that's why I absolutely love what I do. I think that helping patients who have been through so much with their prostate cancer treatment, regain a part of their life is very rewarding. So just some websites and things like that. So like we discussed, there's cures and solutions we have for sexual health, urinary control, and so if anyone wants to come in and speak with someone in our team, we would love to talk to you and go from there. So happy to open the floor to any questions and just have a conversation and answer anything from y'all.
Let's save the questions till the end. Just
Oh,
because
okay.
of the recording aspect of it.
Okay.
All right. Did you want me to go ahead and shift into? Let me flip through these last couple slides here to get the full presentation in. For this slide here, when we're through here, if you would like to schedule a 30-minute private session with me, I'm happy to do so. Here's a URL that you can click on or scan a QR code, and it'll take you right to my schedule, and we can go ahead and put some time on the calendar for you. And I can do that in person as well. And then lastly, here is Dr. Babbar's information. At this point, I'm going to take a few minutes to share my journey with prostate cancer, and feel free to enter your questions into chat, and then we'll get to those afterwards. So I was 43 years old when I was diagnosed with prostate cancer. That was 9 years ago. And at the time, I had 4-year-old twin boys, and it was advanced enough that I was in for a prostatectomy within 2 weeks of my diagnosis. I had no known family history, and I had no symptoms. I just lucked out with a primary care physician that started testing PSA at 40 years old. And so we got the diagnosis, and as all of you have known what that feels like, it wasn't a lot of time for me to wrap my head around that diagnosis, both at my age and having such young kids. And so if I was told anything about the outcomes of a prostatectomy, like the erectile dysfunction or the incontinence, that was really the furthest from my mind. All I heard was cancer. He would talk, cancer, talk, cancer. And so my whole focus was to get the cancer out, save my life, and be there for my boys to grow up. And so after I was done with that prostatectomy, I met with the surgeon, and he told me that everything went really well, and it was nerve sparing, and I should have no problem restoring my erectile function and my continence, and I'm good to go. And so off I went. I started using the vacuum erection device, as all prostatectomy patients do, to start doing some therapy on the penis to get it, active again. And my primary care physician started me on the PDE5 inhibitors, the Viagra, and then we tried Cialis, and then we tried different doses of them. And over time, as many of you know, we got to a point where they were no longer being effective anymore. And so I went back to my primary care physician, and he didn't have any other options for me. So on my own, I did some research, and I identified a urologist at another practice and a very well-known academic institution, and I went there, and all he wanted to talk to me about was injections. And so I did that for a few months. And the injections worked for me, but they were not a good fit for me. As Dr. Babbar mentioned earlier, there is definitely a lack of spontaneity there. You have to keep the serum in your refrigerator or your freezer, so you literally have to be at home around your kitchen if you're going to need to access it. And I was at that point where my marriage was starting to fall apart, and I was soon to be a single man again, and that was just not an option that was going to work for me. And additionally, when you use the injection, some men will experience kind of a dull, aching sensation, and that was something that wasn't comfortable for me, and I didn't like the sensation that gave me. Not to mention, there's not as much control over when that erection goes down. And in some cases, as Dr. Babbar mentioned, it can cause a priapism, which does last longer than 4 hours. And then when that happens, it's a very, very painful and likely damaging process to get that fixed. So after I tried the injections, I decided that that was not a fit for me either. And at that point, I wasn't aware of any other options. And so I reached out to a men's clinic because I heard about them on the radio. And the men's clinic wanted to tell me, all they wanted to give me was injections and pills. And I told them that I tried both of those and I definitely was not wanting to go back to the injections again. They said, well, our pills are a proprietary formula. We make them ourselves and we have great success with them. And, you know, as with the shockwave therapy that Dr. Babbar mentioned, they are all cash pay at these men's clinics. And so I gave them my money and had no results. And they knew that I was a prostate cancer survivor, and they should have known that there was a very small likelihood that they were going to work for me. So once again, there I am, 46 years old, divorced, 2 kids, and I can't get an erection. And, you know, if any of you are starting to experience that erectile dysfunction, you know the mental anguish that it creates, the feeling of loss. You've lost your self-confidence, you've lost your manhood, and that permeates throughout your whole life. I mean, I could feel those effects at work and with my family, and it was just a downward spiral that I didn't see any end to. And then I heard about one of these seminars with Boston Scientific and learned about the different therapies. And I was like, wait a second, where has this been? Why didn't I know about this? And so I was referred to a physician, and within 3 months, I had an AMS 700 implanted. That was in May of 2019, and it was absolutely life-changing for me. The procedure was outpatient. It was a little uncomfortable the second day, a lot of uncomfortable the second day. But then after that, once you ice it and get on some medication, I was up and about within a couple of days. I was working from home within 3 days of the procedure, and I was back in the office within a week. So it was not debilitating for me by any means. And within 6 weeks, I was sexually active again. And literally like tears in your eyes when you see that erection happen for the first time, because it was something that you so deeply missed and never thought that you were going to have again. And so I am pleased to say that I'm now remarried again, and life has been good. As for the incontinence, I did not experience severe incontinence. I actually experienced what Dr. Babbar mentioned near the end with the climacturia. And so I have that sling that he referred to at the end to help minimize the ejaculation of urine during orgasm. And so all that's been working well for me as well. And taking off my Boston Scientific hat and keeping on my patient hat, I will say that as with many of you that are experiencing erectile dysfunction and potentially had the prostatectomy, you do experience that loss in length. And over that 6-year period, I was experiencing loss in length in addition to what I lost at the prostatectomy. And from my personal experience, the implant helped me to regain some of that lost length back again. It certainly didn't put me back to where I was when I was 18, but it certainly helped to stretch over time and give me that length back again. And so that was, again, something that was incredibly important to me. And so the last thing I would share is that it is definitely a couple's problem, and that, you know, bring your partner in. I'm happy to meet with you and your partner one-on-one. We can talk about these options. You can look at the devices. You can feel them. Dr. Babbar and the urology group are there to support you as well, and go through it together, because there's a lot of emotional anxiety on both you and your partner as you go through this journey. And so going through it together is super important. And so with that, let's go ahead and open it up to question and answer for both myself